Welcome to our second webinar, Daily Toothbrushing, as part of a school-based educational curriculum. This is the second webinar undertaken by the All Health Group of the World Federation of Public Health Associations. My name is Professor Raman Bedi, and I will be your chair for this morning. I fully recognize that many of you from all over the world are coming into this webinar, and I want to thank you, those who are starting very early for them, and for others, it's the end of the day. But we have a number of speakers from different parts of the world who will be sharing their experiences and different concepts of undertaking toothbrushing in schools. Next slide. As I said, this is the second webinar of the All Health Working Group, and the second of a number that we are undertaking. But we have to say thank you to our sponsors, the University of Geneva, the Global Child Dental Fund, and to Colgate-Palmolive. This webinar will be live streamed and placed onto YouTube and other social media platforms. And we want to say thank you to the speakers for agreeing that this can go live and that the slides they present will be freely available on those sites. Next slide. Next. I'm based in London, and I was the former Chief Dental Officer for England and currently the chairman of the All Health Working Group of the World Federation of Public Health Associations. I'm a pediatric dentist and have undertaken a number of school-based programs in different parts of the world, as also the chairman of the Global Child Dental Fund. Next slide. Our speakers will be Professor Jaime Elderson, Professor Sonia Grossman, Dr. Alex McCohen, Professor Mahesh Verma, and Professor Rosario Casaro. Next slide. Jaime Elderson has undertaken some of the largest school-based toothbrushing programs in the world. He has convinced the City of Mexico to introduce mandatory toothbrushing for primary school children. Jaime has held a number of positions, and one of them has been the chair of the FDI's World Oral Health Day, and he has undertaken a number of different roles internationally and nationally. Next slide. Professor Sonia Grossman is based in Rio de Janeiro in Brazil and is a professor of dental public health. Sonia has worked on a number of programs, predominantly school-based in the community and with children. She's been a consultant for the Global Child Dental Fund for a number of years and has written several books which are widely used throughout the world. Next slide. Dr. Alex McCohen is based in Glasgow as a reader at the University of Glasgow Dental School and is one of the key individuals leading the well-known project called Child Smile. Alex will be sharing how Child Smile is changing the whole landscape, not only for Scotland, but also for the United Kingdom. Next slide. Professor Mahesh Verma was in the past the Dean of the Dental School in New Delhi, but now is the Vice Chancellor of Guru Gobind Singh and the Indraprastha University in New Delhi. He's held a number of major positions in dentistry, including the FDI, but Mahesh is also the first dentist now to be seconded onto the Medical Council for India. Next slide. Professor Rosario Casaro is based in Italy in Policlinico San Donato and is the representative of the International College of Nursing, who is going to share with us his experience of how to integrate different programs in schools using school nurses. Next slide. The World Federation of Public Health Associations is an international not-profit organization based in Geneva. Most national public health associations are members of the WFPHA. WFPHA, and its main role is to coordinate policy across the nations and also to influence policy at the World Health Assembly and within the WHO. Next slide. I'll hand over now to Professor Elderson, who's going to walk us through the very impressive project that is being undertaken in Mexico. Jaime.
Hi, good morning, everybody. I'm broadcasting live from Mexico City. It's very early in the morning, and I hope you'll bear with me. Thank you, Raman, for the invitation. I think that we have a very interesting case to share with you this morning about mandatory daily brushing. We were able to present a law in Mexico, and I will let you know how this story went. Next. As you may know, the concept disruptive innovation, it's something that comes into a market and creates, by disrupting an existing market and value network, displacing established market leaders and alliances. And this is a concept that was introduced by Clayton Christensen from Harvard School of Medicine. And in short words, next, it creates the when we apply it to dentistry, we can say that the dental caries prevalence is very high, and it's rising in most countries, especially developing countries. The access to oral care is very limited, especially developing countries. Sugar daily intake is rising worldwide, and school is a great place to acquire and solidify good habits at early ages, plus an excellent opportunity for a daily experience. Next. Some of the projects that are being done by the Mexican Dental Association Foundation, which I'm very proud to chair for the past 9 years, includes something for preschoolers. Then it was the first real pilot with 30,000 kids on daily brushing. Then we started to do daily brushing with fluoride varnish. And now we're also interfering with in public health with an oral cancer awareness and early detection program. Next. You see, we have a vision at the foundation, which is the basis of this. Any reactive program in dentistry will fail if it doesn't include a very strong educational preventive program. And all of a sudden, one of these big millionaires of the world would come to Mexico and give us all the money to clear and get all the children fill their cavities in their mouths. We are talking about a lot of children in Mexico. It wouldn't be good, because by the time we finish sealing all those cavities, we will have to start again, because dentistry has abandoned in many ways the importance of a very strong educational preventive program. So that's why this was the basis for our project. Next. You see, when we say Mexican children, who are they? Well, in kindergarten and elementary school, we have 28 million kids. 55% are below the poverty line, 7% in extreme poverty, 98% attend school, 94.2% of the kids are vaccinated, 40% live with one parent, 7% are malnourished, and 70% overweight. Mexico has a #1 place in child obesity worldwide in elementary school years, 90% of dental caries prevalences in ages 6 to 12, and very limited access to oral care for the underserved. Next. And as you can remember, the World Federation of Public Health Associations came up with the basic right of children for oral health in 2013. And then 2 years later, we invited Professor Betty to Mexico City, and we tried to take this out of the drawer, out of a file, and created a reality where the government, the community, and the dentists, the parents, the children, everybody would try to make this oral health basic right for children a reality. Next. That's how we started to introduce all these people. Now, it all started by a preschool oral health program that started with the Mexican Dental Association in 2008. Over 120,000 kids were treated in 11 years. That program still goes on. But we found that we can include many good habits: washing hands, healthy non-cardiogenic lunch, daily brushing, and fluoride varnish applications twice a year. It lasts a full year, but it includes dental volunteers, teachers, and parents for this to work. But it included dentists. So it was a very beautiful program. It still exists, but it's based, if we don't have the volunteers, dentists, then the program doesn't work. Next. As you can see, a lot of volunteer members of the Mexican Dental Association were eager to participate in this program, but it was only for the preschool children. Next. Then we migrated to school-based daily brushing at elementary school, where we were able to do a pilot test with 30,000 kids and it lasted 4 years, 30,000 kids every year. And we tried to introduce what we've learned from the preschool: wash your hands, eat a healthy food, and brush your teeth. Next. Next. Every child was given a toothbrush, a toothpaste, a cap, so that the toothbrushes will not contaminate with one another. And these things stay in the classroom. They don't go back home. In Mexico, we have a problem if you only give away the toothpaste and the toothbrush for the children to take home, then they wouldn't bring it back to school. Next. The brushing was done after the meal they had in school. Some had breakfast, some had lunch, some had a meal, some had an afternoon snack. So the brushing came after that. At the same time, we started a program with the Mexico City Family Services program. We started with 5,000 kids that will get fluoride varnish once in each semester, twice a year. Then that number grew to 10,000. And this year we were very happy that the new chair for the family services in Mexico City decided to go for 180,000 kids just in Mexico City, that they have fluoride varnish twice a year. And we provide them with toothpaste and toothbrush so we can have both. And as you can see, it's a party where parents come in and we have the fluoride varnish application in front of everybody. There is a clown or an entertainer. And then this happens twice a year in one of their centers. Next. Now, the lessons we got from the first pilot of the 30,000 kids for 4 years is that oral health education must be considered in the school curricula. It used to be when I was a child, and then it disappeared. Kindergarten and elementary school are great to embed good habits in young children. And good habits are a gift for life. We know that most of these children, when they brush and they start at age 3, by the time they finish elementary school, they're going to have 9 years of daily brushing. And some of them, most of them, that's the goal, fluoride varnish twice a year. Next. And then teachers can become strategic elements in oral care. We always thought about the dentist, the dental nurse, the dental hygienist, but this time we're exploring it outside of the premises of the dentist, both in the dental school or in their practices or in the public infirmaries. Next. Now, the lesson from the first pilot of fluoride varnish plus daily brushing, that was interesting. Next. We saw that the government can spend money on oral health that does not come from health ministers. This was a very big discovery, because we are used to think that the only one who can come up with the funds, it's the Minister of Health, and they're always treating something else. And then dentistry comes in many, many countries at the very last end of the budget. But here we were using money from family services, from the Minister of Education, and we had to go to the source of the money, which is normally not the minister, but the Congress, both in either the city or in the whole country. Next. Now, in preschool programs, remember, we were dentist-based. We need volunteers. In school-based daily brushing, it's teachers-based, and teachers go to school anyway. Next. It was the Mexico's disruptive opportunity to improve children's oral health. Next. But the next challenge was how to move from 30,000 kids that were brushing every day in Mexico City in 100 schools to 28 million kids in the whole country. Next. Now, the programs, the programs finish when the flow of products ends. We have all done in parts of our life a program where we get a toothbrush or toothpaste from a company. But when there are no more products, this is the end of the program. The programs are suggested to constant supervision and positive measurements, or they get discontinued. But a law is not subjected to evaluation, at least not in Mexico. So bingo, then we had a good opportunity to do something really different. Next. We're almost done. So we started to have different kind of forums, but this time we went to the source of the money, which is the Congress. In this case, the Congress in Mexico City. Next. And finally, we were able to produce a law that said that at the beginning of every school year, the Mexico City government has to buy every child that is enrolled in preschool or elementary school one toothpaste, one toothbrush for home, and one toothpaste and one toothbrush that stays in the classroom for the duration of the year. This is the Mexico City mayor, the day he was signing the law. It was a very big thing in Mexico. It was the first city, as far as I know, that will allocate money or a budget every year so every child can get a toothpaste and a toothbrush at the beginning of the school year. And we're talking about 1.25 million kids. The toothpaste and toothbrush were in these packs with no political message whatsoever. Next. It was a product by Colgate because Colgate in New York was very kind, and they give the first lot for 1.25 million kids on top of what the government bought. Remember, the important thing was not to give them the toothpaste and the toothbrush. The very important step was to get the government to put the money resources to give it, and then to hire 10,000 volunteers that were delivering each pack for each day, and it took them about 2 months. And we needed a platform so the teachers would get trained. So we got an educational platform which has information for teachers, for children, and for their parents. Next. It has different even games so the children would get engaged and the teachers. Now, it took 5 years. You know, it's not that one day I woke up in the morning and I come up with a law. The first workshop was in May of 2012, and the law was signed into law on April 19, 2017 by the head of Mexico City. And then this is when we got another lesson. We have to go to the source of the money, which in this case, it's the Congress. So we're in these pictures, we are in the Mexico, now the country's Congress, trying to get this at the federal level. Next. Now, I can tell you very proudly that we had another state now in Mexico, the state of Veracruz, who already passed the law. In this case, they're not going to give the toothpaste and the toothbrush, but they agree that the toothbrushing has to be mandatory in the classrooms of all the state of Veracruz. And this goes now to 1,200,000 kids that now add to what's been done in Mexico City. Excuse me. Plus what we're doing with family services now all over the country. So altogether, it's over 3 million kids who are brushing every day starting this school year. We go by school year, not by a calendar year. Next. We're almost done. Now, the law exists in Mexico City with 1.3 million kids, in Veracruz with 1.1 million kids. And we already presented the law, and it's in different parts of the process of vetting and then voting in the states of Baja California, Jalisco, Guanajuato, Nuevo León, Campeche, Yucatan, the state of Mexico, and the Senate at the federal level. But the federal level goes very small, very slow. So that's why we started to do each individual state. Mexico has 32 states. Altogether is going to be 28 million kids ages 3 to 12. Next. So it was a very fast, drawn view of the project. But I hope, and I'll be around if you want to ask me any questions or write me directly. You can find me in either Instagram or Twitter with jedelson55, or you can write me an email at jedelson@mac.com. Thank you very much.
Jaime, thank you very much for that. It's very impressive. The numbers are staggering. But one of the things that you've highlighted is that toothbrushing is a learned habit. Parents teach it to their children, but actually it is a learned habit. And one of the best places to enforce it is schools. And what's impressive about your program is that you built it into the school curriculum so that the teachers are teaching dental health education messages, and they are actually part of the learning that a child expects to receive when they're at school. I just wondered how you found the teachers' responses to this program.
Well, the smaller the children, the best the response of the teachers. And it's been a process. I mean, we started in the school year 17-18, but every year we get better. Every year more teachers are involved. We have a platform where they can get their training and they get back like a diploma that they pass the daily brushing. Now, we dentists try to make the teachers dentists. That's wrong. The teachers only show the basis for the children, and there is a time for the brushing, which is not considered a loss of time. That was also very hard at the beginning. But as the teachers understood that we were there to really help them, and that they know washing hands is very important before you eat or after you go to the bathroom. So brushing is very important after the meal. Now, this is not the best time to do it, but remember, we're more than teaching the children to brush. We are creating the good habit of eating. And before you eat, you wash your hands. After you eat, you brush your teeth. And the best thing is that in one of the epidemiological studies that were done, and by questioning the parents, they told us that now the children are going after them at night. Mama, are you going to brush your teeth? Papa, are you going to brush your teeth? After they have a meal at home, which used to be the other way around. You know, the parents would have to go after the children. So that means that we're doing something good. And the teachers, to finish your question, it was our concern, but teachers who have a heart for teaching know the importance of these things.
Jaime, thank you very much. I think what you've highlighted, which is so often forget, is that we don't want to keep dental health programs like toothbrushing separate. It's not something that just comes to a school, is undertaken, and they leave. You've integrated it into the school curriculum, the teaching, and it's part of the daily life of a child in school. So thank you very much for that. There'll be opportunities when we have our Q&A to develop this further, but can we have the next slide, please? I want to introduce, moving from Mexico to Brazil, Professor Sonia Grossman, who's been undertaking a number of studies. Sonia, we can hand over to you.
Good morning, everybody. Thank you, Professor Ramon, who invited me to speak on this webinar. And when I was preparing, I was thinking, why should we tell people that brushing and toothbrushing at school should be something relevant? So I came to United Nations Sustainability Agenda, and we are the number 3 because we are health. And through toothbrushing, we can promote health. So that's one big message, that we can achieve health through oral health. And if you see the picture above the agenda, is that why health is a problem that causes most disability. So 10 years ago, health was the 9th problem that cause more disability. 10 years later, it becomes, it increases much more disabilities caused only by oral health. And if you join oral health with other disease, it causes more disabilities. So disabilities would be days that are not work planning, work in plenitude, or days that people lost doing tooth pain. Next, please. So in the left map, we could see why that school brushing is so important. It says the caries deciduous T, how does it affect by this daily, that's a measure that's day adjusted by incapability on years or loss due health problem. So in Brazil, we have a rate of 0.44 or 2.42. That's the highest, and it's a very big score if you consider that 5 is the maximum of lost days due to caries in deciduous tooth in the world. In Brazil, we have a very high score, and dental caries is the consequence also of death, loss, and years lost. And if the children has dental pain, he cannot pay attention and he cannot graduate well and he cannot have a good job, and then it's a cycle of poverty. So one big challenge to change this, it's inside public health brushing programs. And if you see, we still have a lot of caries in Brazil. Although the DMFT has decreased very much, the whole DMFT in Brazil is 2.07, but in some areas of Brazil, like in the north and in the south, it's still a high DMFT, and all of it, the majority is due by caries. Could you pass next, please? So that's why we have a law, and we have a program that's an official program from Strategy of Family. And this Strategy of Family has indicators how much the children should brush the teeth, and it's the government pactuated these indicators with the state and the municipality. And we can see by this slide from 2010 to 2015, the historical index and how much they had increased and achieved. And then you see the last graphic, the average, it shows that in each state of the country, the indicators are not stability. They have been going and down all the time. And if you see the last one, just in Rio de Janeiro, we had pactuating the state a goal for 2.5 school children brushing every day, but we achieved only 0.13. Next, please. So how to work regarding this United States agenda, sustainability for 2030, to reduce disparity in oral health. So in that case, toothbrushing is a part of school-based curriculum. It could promote health through oral health, because we always give, as Professor Jaime said, oral education. Oral health is an integral part of overall health and important to prevent, treat, and maintain. We should train dental students and dentists to act in a more humanized way according to the school children group needs. In that case, we don't use varnish because we still need to make automatic restoration. It's important to have health education as completed tools, and supervise toothbrushing to improve social responsibility, not only by the graduate students, the school children, and the dentists. So to create, in that program that we used to have, we were used to not to use the teacher, because in Brazil, the teachers receive a very low salary and they are already oversaturated with programs. So we create like a school groups of monitors. Those that are bigger, more age, they become responsible for the youngest. So in that case, we also promote them by diplomas and certificates and medals and everything. So that's a way to develop leadership in school children, in dental students and dentists, and to promote universal interchange experience also, because we have students coming from ACTA and now from Portugal to join the program. Next, please. We have each year a work team of 5 post-graduation students, 7 graduation dental students, and 3 students from ACTA. And we had been in many different schools and always integrating oral health in health. And we have this in the left, the big mouse, and it's a big mouse where the students and the teachers go inside. One side is dental caries, the other side is periodontal disease. And we have in this integrated students from the hospital of Federal University of Diabetes. We have from also cardiologists, and to all that want to integrate are welcome, so we can show the relevance of oral health in general health. Next, please. And they are using, oh, sorry, just come back, please, one. We are using the booklet of oral health, maternal and child orientation also. We have many kinds of orientation, of education. We also have, but we have to be adjusted to each place we go. Next, please. Next, please. We have some activities that you can see the mouse I told you, the children inside with the teachers, and we have health education. And we also do this, we brush themselves, we show the parents how to be in position, and how we also use the methodology to do, and then the children do themselves. And when they go to place where they don't have any possibilities to go to the bathroom, we have our this, if you can see in this picture on the right, on the up, we have this portable that are for brushing. And we also have the more adults one, the teenagers that are going to be responsible for the rest of the year. Next, please. We also have been doing this with pregnant women and using the oral health booklets and in unprivileged areas. And the first graphic is for gingival index bleeding, and the second graphic is for visible plaque. And we have been showing that also doing oral health education and motivation together, not only teaching, but having a strategy of working together, we can decrease gingival index and visible plaque. Next, please. We can also we have been doing this a couple of years, 3 years, and this graphic shows how we have been decreasing the number of caries of school children when we act together with doctors or physicians, pediatricians. So in order to make it better, we make a common chart of dentists and pediatricians. So if the patients go to pediatricians and don't have sign that he has been going to the dentist and he's not in a pain or something urgent, he has to go to the dentist before and come back to the dentist. In that way, we decrease 9% of dental caries, and it's in a very unprivileged area nearby the dental school. Next, please. And conclusion and challenges in Brazil. Our team work only once a week. So we have 30 weeks a year. That's the school calendar of the dental school. We impact 2,400 school children per year when we do our normal program. When we have a social action that we include other areas and other programs together, then we can impact much more. It's a higher number, but it's only one day. So we can impact 1,300 school children only one day. And this used to repeat it each 3 months. but in each place, not in the same place. You have to remember that Brazil, it's a continental country, it's bigger than Europe, and Rio de Janeiro itself is also very big. So although there are many isolated successful programs in caries concerning school children toothbrushing, in Brazil, especially in the state of Rio de Janeiro, we are far away from the goals that the own government established. Due to the lack of government resource, it's necessary to implement private partnerships in order to improve toothbrushing in dental schools curriculum and benefits a bigger number in school children, like Professor Jaime said in Mexico. Next, please. As we had been working that way not only in dentistry, but more interdisciplinary way, we had been able to launch the booklets of Global Child Dental Fund and Brazilian Society of Pediatrics. And in the last Congress in 2017, we only launched. And last week, we are in Porto Alegre because this Congress is each 2 years, and there were 9,000 pediatricians. So we had a symposium of oral health, and it was really amazing how people were interested in getting engaged in it and how much they need to know. So we divided in a symposium of oral health in the Pediatrician Society, and we make a workshop of brushing and toothbrushing and how to indicate each toothpaste also. And now we have in the future, we launch now the oral health booklet. We will do it in Portugal next year. It's already ready because it's Colgate and Brazilian and Portugal make a combination and they are working together and it's already ready. So I think we should work and improve health, oral health through general health. And then we get more and more visibility. In Brazil, it doesn't matter if you have a law or not. We have a law that the water should be fluoride, but not necessary it happens. So it's really necessary to be working, checking, and showing that we could progress. And I think we also now had the work with teenagers pregnant with diabetes, because we know that periodontal disease can lead to the delivery of preterm, and we have a great number of teenagers pregnant, and they can develop unclinical diabetes. So we are working now with this, also with our booklet as a base for information, and we have the toothbrushing supervised and to increase the motivation to do it. But we are still need a lot of work and also need help. And the most important thing, it's necessary to make agreements with private organization in order to do that. Thank you very much. And if you could come back to the last slide, my email, if anyone would like to write me, is sonia@dentistas.com.br. Oh, I'm not seeing. Oh, it was in blue. Okay. I am.
Sonia, thank you so much. Thank you for that. It's very impressive to learn what's happening in Brazil. I suppose today's key issue is that so often toothbrushing is parallel and it's just parachuted into schools and then it leaves. And what Jaime showed us in Mexico, how important it is to make it a law, a mandatory. Toothbrushing must happen, and therefore receiving funds from more traditional sources like education, and then building it into the curriculum. I was very interested in your work, how incorporating it into the life of a school, you used other pupils, you used leadership. So you noticed that you had older children who became all health leaders. Do you want to just share a little bit about how that process happened of getting other pupils to become role models and also educators with regard to all health?
Thank you, Ramon, for the question. It's very impressed because when we go to a school, we had that experience in a school in the municipality of Resende, and Resende has the highest municipality school in Latin America. It's a huge dental school, huge school. And when you say you have only a small amount of toothbrush and toothpaste, you have to decide to whom to give. It's a challenge. And then the others are also interested in see what's happening, why they cannot be part of. So those that come interested, when they are part of, they become very, very proud of being that. So we make some bottoms, and then we give them like a leader toothbrushing, and of course we give them we also make a kind of it's not a t-shirt, but it's something to put plus the t-shirt. And once a week they are going to the schools and say, who haven't brushing, we are going to have one brushing day. This was coming in this international program that we did together in ACTA. And Resende, although it's the biggest school children in Brazil, in Latin America, they don't have this program of school brushing every day. The strategy of family, they are very organized, the most organized of the state of the Rio. But even though they cannot get toothbrushing for everybody. So this is make teenagers feel very important because they are responsible and they get more than the teachers, because the teachers receive the salary doesn't change, but they receive a certificate saying they had been in the program and they had been leadership. So this is very proud of them.
Good. Thank you so much. We'll be able to come back. I think the key message here, Sonia, for us is that trying to make toothbrushing part of the life of the school and the community. And you showed us something very unusual about incorporating older children to become part of that. So thank you for that. We'll come back in the Q&A and maybe we'll come back and revisit this. But if I could have the next slide, please. Dr. Alex McCohen is based in Glasgow, and he's been part of what is now becoming in Europe a very impressive program called Child Smile. Alex, we'll hand over to you.
Thank you. Hello. I'm going to present the results of our evaluation of our national toothbrushing program. Next. And supervised toothbrushing was one of the earliest components of our national Child Smile program. Next. So I'm going to present some published results from our evaluation, and that's in GCDFund. If you do look at previous, please, if you do look at this paper, don't forget the appendix, which has quite a lot of information on it. So some dates. Next. Next. So some milestones. We identified that oral health was to be a priority for children. It was also decided in Scotland that we couldn't have fluoride in the water. So then an oral health action plan was developed. Next. So Child Smile began rolling out in 2007. Then in 2011, the full rollout was complete. But the previous toothbrushing rollout started in 1986 in Lothian, then rolled out Shetland, Fife over the years, then Ayrshire, then Lanarkshire, then Fleece and Galloway, Forth, Glasgow, all the way down to 2001 to the final one in the Western Isles. And the toothbrushing gradually increased in each health board differently and at different times. So we were able to access that data essentially at a health board level. And the dental decay data from the National Dental Inspection data is also available in these years. So this is the DMFT data that we used to link in with the toothbrushing. So next, so this is the raw data, mean DMFT in each health board over time. So that's a bit confusing. So next, so then we set the calendar time to be ×0, which is different in each health board. Next, then we smoothed it into 3-year groups. Now, as you can see, next, then, and then again, actually DMFT was rising prior to the beginning of the rollout, which helps to suggest that the toothbrushing results are against a secular change that either was flat or slightly going up. So, and in terms of results, so the drop in DMFT was 0.45, 0.41, went up to 0.73, then became nearly -1. And in more affluent kids, the drop's 0.4, but for the more deprived kids, it's much higher than next. So the most deprived kids, the drop's much higher than that, so that's very good. Now, but what I haven't discussed is the increase in intensity of toothbrushing. It's not like each health board just started. It gradually came up. So how do you deal with that? It's a wee bit of a statistical issue. So next, so here's one health board, Ayrshire and Arden. So the vertical line is ×0, which in this case is 94. The blue line is the toothbrushing going up. The black line is the toothbrushing coming down. So what we're looking for after T0 is for toothbrushing to come up and DMFT to come down. So next, and we'll just go through all the health boards next. So as you can see that pattern in each health board separately. Next, next. So that's Forth Valley. Next, Galloway, sorry, Grampian. Next, that's the big one, Greater Glasgow and Clyde. So as you can see, this crossing pattern does seem to be, you can see that in each health board. Next, next, next. That's Lothian. Next, Orkney. Next, next, next. Now, this one is a bit unusual, as you can see. Tayside, their drop is just before T0. That's because they had other things going on locally in that health board that started before the toothbrushing rollout. So next. So back to the problem. So what we did was next. So you've got the increase in trend for toothbrushing. Next, decrease in trend for DMFT. So next. So we did a meta-analysis. We correlated these 15 sets of paired slopes and weighted them by population size. So next, here's a bubble plot, which is big bubbles is big boards, small bubbles, small boards. And as you can see, there's a very strong trend there. Next, and apart from that one, that's Tayside, which is anomalous. So next, so the correlation coefficient weighted in all the boards is 0.64, which is quite strong, significant. But of course, if you exclude the Tayside board, it's -0.9, which is an extremely strong correlation. So we also looked at other things that might be going on at the same time as the toothbrushing. And there's no real evidence that any other intervention in that age group could be responsible for that improvement. Next, we also looked at other health outcomes. That's DMFT coming down in green. Previous, please. Previous slide. Yeah, and hospital admissions for non-dental things is going up actually, and obesity is flat. Next. So we did conclude that toothbrushing was associated with a very strong decrease in oral DMFT. Next. And next, we also did a cost analysis of the toothbrushing program to see if, you know, how the benefits panned out against the costs of the program. So we used, in collaboration with health economists. Next. So we estimated the program costs in each board. Next. And then we also looked at the treatment costs. Next. Next. So, and of course, if you can save treatment costs, that might pay for the cost of the program. Next. And here's a summary of the cost analysis. Now, the top line, the blue bars, that's the cost of the programme. The green bars underneath are the savings from the programme. And as you can see, gradually, the green bars are now much bigger than the blue bars. And that means that the toothbrushing programme is actually saving millions of pounds. And nowadays, that green bar would be even better because, of course, DMFTs continue to improve since this data was analysed. So in conclusion, next. So in the 8th year of the toothbrushing programme, the savings were more than 2.5 times the cost of the programme implementation. So next, next again. So in conclusion, this toothbrushing programme really works and also saves the National Health Service millions of pounds. Next, so next. So who's next to attempt a toothbrushing programme like this nationally in schools? And I think we've shown that you can achieve really good results. Thank you. That's the end of my presentation.
Alex, thank you very much. And Charles Smile has gained a reputation. I think your team has done two things. One is shown the oral health improvement, the reduction in DMFT, but it's also shown the potential cost savings, which has been very impressive. And I suppose that those two issues have been the reason why other boards, health boards, have all begun to adopt it. So I think that's been a very impressive ingredient, that if we are to introduce toothbrushing campaigns, then if we collect that type of data, it does attract other areas to embrace the issue. So where do you think did you introduce into Child Smile fluoride varnish or any other interventions? Sorry, you're still muted. We need to unmute you. Go ahead, Alex.
Right, yeah, Child Smile now includes lots of other things as well as the toothbrushing. And in the post-toothbrushing era, we're currently evaluating fluoride varnish and the other parts of Child Smile as well, and putting them all together to work out which parts of Child Smile may or may not work.
And this is all done in the school setting?
Well, other parts of Child Smile are at home before you go to school and in dental practices as well.
Okay. Well, thank you very much. In the Q&A, I think that we've had a number of questions already from the audience about this, and we can pick that up later. Can I have the next slide, please? We now move from Scotland to India, and Professor Mahesh Verma is going to talk about different school-based programs in the Delhi and more widely within India. Mahesh.
Could I have the first slide? Raman, while you were you asked me to participate in this webinar, being the dental school here, in my work as a dean, and we had a very unique school health program, mobile dental clinic program, as well as which was integrated later into school health program. I mean, I was expected to answer 4 questions, and I would restrict my presentation to answering these 4 questions. And the first question was that how could a dental school engage in school-based dental toothbrushing? And in India, we, as you all know, that we have a huge number of dental schools. We have nearly 315 dental schools, and almost 26,000 students they pass out from these schools, for graduate, undergraduate level. And we have a very intense public health training program embedded in the school curriculum, and where they are exposed to preventive dentistry in 3rd year as a part of public health dentistry subject, and also in 4th year, along with other clinical subjects like pediatric dentistry, orthodontics, and other specialties. And they are expected, these students are expected that they learn while they are posted in a public health dentistry posting in the dental college, or during the camps or adopted schools, as part of their training. They learn the plaque control interventions, how they can measure and how they can practice these different indices in plaque control and oral hygiene indices. And they also, during their training, they also expected to learn to develop different health education materials like posters, models, infographics, and other various different innovative games and working models, so as to not only influence and educate the adults, but primarily, basically, the school children. And also, it's also expected that every dental school in India would adapt at least two schools as part of as a part of their training. So if it's mandatory that every dental college institution will have attachment with at least two schools. And I know that most of the dental schools have many more schools where these students are posted not only for training, but even otherwise, because somewhere we feel that the school health programs, especially school dental health program, should be taught to the dental graduates, because eventually they must practice this at when they pass out from these dental schools. Next slide, please. So school-based health programs in India already have, we have a midday meal scheme. Most of the states across the country have a midday meals scheme, but I think there are very few states where toothbrushing is mandatory. It's a part of these these school-based health programs. But they are taught hand washing, and they are provided meals. And I think it would be ideal, like what Hami said, what they practice in Mexico, that they wash the hands, they eat the meals, and afterwards it's followed by brushing. So this component is primarily lacking. And I think as it has happened in Mexico and in Brazil, that some of these companies, as a part of CSR activities or even otherwise, promoting this effort, I think support from industries really needed, because they could provide the kits and they could provide the materials and toothpaste for carrying out this, because this is a humongous amount of work, which is especially if all the schools have to be involved in every state. Next slide, please. So some of the examples from India, I want to share with you that in India, I think the Delhi state is doing rather well, especially when it comes to health standards. And there is a very robust school health scheme in Delhi, and this scheme is applicable to all the Delhi government schools, and also some of these schools are although private, but they're aided by the government. So there are nearly 1,600,000 school children in these in these schools where school health scheme is already being there. And there is another program which is called National Oral Health Program, NOHP, and which is of course not the central, which is not a state government program, because these schools are under the state government, but the central government has a National Health Oral Program, wherein they have done many endeavors. And one of this is that they have developed a training manual for all the teachers, so that these teachers, they are trained, and that these teachers these teachers in turn, they teach the brushing and teach the dental health education to school children. And we have a very very long, very old Bright Smile, Bright Future program by Colgate, where they have been providing through the Indian Dental Association the free kits and other oral health education material, charts, model, brushes, all those things for dental screening. And I think it is expected that every branch, we have nearly 500 branches of Indian Dental Association spread all over the country, and every branch, is given some money every year, and that money is supposed to be used for this program called Bright Smile and Bright Futures. Next slide, please. Next slide. We also have a very strong Indian Association of Public Health Dentists. We have most of the schools are running postgraduate program in public health dentistry, and they have adopted November 7th as a National Toothbrushing Day. So there is, there's a huge awareness that this toothbrushing must be carried out by school children in the schools, and not only that, not only on this day, 7th of November, which is used, as a just to awaken, just to sensitize the school children all over the country that for awareness about brushing, but also other health education sessions, advertisement for promotion of oral hygiene, and health exhibition, etc. Next slide. Now, what is the advantage a dental student in schools they visit? Why, as I think we've seen it happening in Mexico, we have seen it happening in Scotland and in Brazil, that because dental students are the foundation of dental education, because these students, not only when they come out, not only they become faculty, but they also teach their patients. And so they can, if they are exposed to this, I think they can contribute to advocacy, participation in community-based programs, and eventually research, when they, pass out and practice dentistry. And only thing that they need, initially they need some leadership, they need to be mentored, they need to be assisted, they need to be handheld, and so that they can, they can ingrain these lifelong skills, and, because this will make their education not only more enriching, but also because what has been seen in the past, that although we study preventive dentistry in dental school, but when we pass out, we do not practice preventive dentistry, especially the large number of practitioners. They focus more on restorations, and somehow the preventive dentistry takes a backseat. And I think dental students, while they are, if they are part of the toothbrushing campaign in the schools, I think they are accepted better, because they can really come down to that level and they can break the barriers. And if they are well oriented, I think they can really look after the children needs. All they need is that they need a little bit of mentoring, and so that they achieve these skills for lifelong, and which would help them in different situations, because every country there's a diverse population, diverse distribution. There are say India also, we have far-flung areas, we have rural, semi-urban, urban, we have metros, and we have areas where healthcare, forget about dental care, even healthcare is not accessible. So I think the students, dental students especially, they also need to be oriented about this, and they also need to be trained so that they can look after all kinds of dental needs to all sections of society. Next. Another example from Delhi, as I told you that in our Maulana Azad Institute of Dental Sciences, we were the first one who started mobile dental clinic project, and this was under the National Health Mission. We had a program from central government where state governments are assisted for health mission in urban areas, and then they came up in the rural areas, National Rural Health Mission. Later it was called a National Health Mission, and they were supporting, funding, providing human resource, providing technology, so that accessible, affordable, and quality oral health care could be provided to the vulnerable population. So under this program, we started this first mobile dental clinic project, which was more like a pilot project. And in this, we had about 6 mobile clinics. And this was started in 2014. And using these mobile clinics, we were we were, because Delhi is a big city, and we still have certain rural areas or areas which is not the main part of the city, which is in the outskirts of the city. So 2 districts of these of the city were being served by through this mobile dental clinic project, and this project was later then also integrated with the school health scheme, which was already in place. And using this while mobile dental clinic and school health scheme, we've covered about 23,000 school children, which were educated and screened. And also now recently we have started a national social NSS, we call it National Social Service Scheme at the institution at the dental school. And the entire objective of this program also is to provide promotive and preventive activities in the schools, colleges, and universities. So this is slightly different, not a typical public health dentistry activity, conventional public health dentistry, but it is mainly focusing on schools, colleges, and universities. And this program, as it is recently started, so we just covered about 750 students studying in different educational institutions under this program. Next. So, basically giving you a little flavor that how this is happening in, all these things are happening in India. But I think, like Mexico, we need also somewhere some legislation or some system where it becomes a mandatory that school children, when they have because there's a midday meal scheme going on in most of the states across the country, that there they are exposed to hand hygiene, and they are given midday meal, and after that followed by mandatory toothbrushing. Thank you.
Mahesh, thank you very much. That's really interesting what's happening in India. I think we're getting the picture that, and the message I think we're trying to convey is not to have toothbrushing schemes, fluoride varnish schemes as parallel programs, just something that is introduced and by a dental group and then they leave and that's what they do. But to build toothbrushing into the life of a school, into a daily habit of a school, and actually part of the education experience. Every parent tries to teach their child at a young age to brush their teeth. It's a learned behavior. And if schools can reinforce that as part of their mission, then this is going to be very important. So I was quite interested that dental schools have that exposure in their undergraduate world to go to schools and begin to understand the culture of a school, to understand how to engage. And that's mandatory from the Dental Council for India?
Yes, mandatory, because there is a curriculum, during 3rd year of their BDS program, they have, there's certain requirements, there's certain work requirements which they have to undergo, before when they are allowed to sit in the exam. So I think it's like competencies, they have to develop these competencies.
Good. Thank you very much, Marsha. Let's move on to the next speaker, and our last speaker is Rosario. You're bringing a completely different element. The next slide, please. A different experience of school nurses and the roles that they can play in this agenda. So, AJ, we need to have the slide up on the screen, please, and we need Dr. Rosario Casoro to start his presentation.
Say that my presentation is broad because I would like to share with you some reflection about how can school nurses be helpful to implement and to support school-based education involving toothbrushing in the program. So going from my presentation, next please. Going from my presentation, I'm going to stress the attention about next Okay, great. About some facts that are underpinning the International Council of Nurses' perspective about the involvement of school nurses in education. And I would like to share with you broadly some facts. First of all, poor oral health may negatively affect a person's quality of life. And considering the student ages, poor oral health could also indirectly affect school performance. We know that a proportion of young people aged under 18 which are seeking for dental care on an annual basis worldwide are increasing. So why? Basically simplifying for two main reasons. On one hand, we have an increased awareness related to the importance of the oral health. On the other hand, we have also an increased number of diseases associated with poor oral health. Next, please. Very helpful in help the educators in defining an environment which is functional to deliver health promotion programs. First of all, I would like to clarify that health promotion is not only health education. Sometimes when we freely speak, the concept of education and promotion overlaps the one and the other. Actually, when to understand my presentation and to understand how can school nurses be helpful, we have to consider that health promotion is a more complex concept which encompasses education, screening, prevention. What does it mean? It means that if you would like to implement in your environment an effective curricula of health promotion, you have to move from education to prevention through the screening to implement a behavioral change in the student. Next, please. Next, please. So, how can school nurses be helpful to enhance the ecosystem related to programs on health promotion? If we move to the next slide, please. The message I would like to share with you is given by the pitfall that sometimes we face with when we try to face with curricula based on multiple messages. So as the faculty of this webinar said, we have a lot of information that we need to consider in our educational program, but sometimes we are focused only on knowledge. Knowledge is a necessary but not sufficient requirement for behavioral change. And when we would like to implement a health promotion program, of course, we have to consider that the best endpoint we can achieve is a behavioral change. So, considering perspective from behavioral change point of view, taking oral health related behaviors and considering them separately in different models of preventive program is much more likely to lead to behavioral change. So the philosophy, next slide please. The philosophy of what I would like to say is to undertake programs that move from information to incentivation. School nurses are very educated considering this paradigm, and this kind of program, which should be considering as an actual path from knowledge to engagement, should start from a clear barrier and facilitator analysis. because every program should be specific for a specific target, a specific setting, and even some specific epidemiology of your countries. So the barrier and facilitator analysis, of course, is in the methodology of school nurses when start to work with educators, is the basis to build a good curricula in the different school programs that move from information with single models to incentivation, because of course we have to consider the settings of our where we would like to implement educational programs, and the settings in some way could represent, in some cases, barrier, in other cases also could be facilitate the perform of healthy behavior. Next, please. So, next slide, please. So, considering the messages I would like to share with you, we have to be aware that daily toothbrushing is a pivotal strategy to achieve and or maintain oral health. We have to be also aware that schools are places that are pivotal to implement health promotion. So educators, teachers have to be aware that their work and the school are strategic, fundamental places to implement health promotion. Sometimes and many times, daily toothbrushing requires a behavioral change. So what I said before means that we have to consider the complexity of the education that is underpinning an actual behavioral change. And an actual behavioral change often requires many elements that could be that have to be synthesized in a clear curriculum educational plan that start from knowledge and move to the engagement of the different students. Of course, as I say, preceded by a contextual analysis of barrier and facilitators. Next, please. In this scenario, school nurses are your partners in creating an ecosystem to supporting health promotions. In the complexity of an educational plan that have the endpoint of a behavioral change, school nurses could help educators, would help teachers in framing the right educational plan at the right time, because the timing of the different targets is very important, and the strategy of the educational plan has to be very specific, considering the target of the educational plan, and also are good partners in considering the barriers or the facilitators of your setting, because the educational plan has to be tailored with some common strategies, but have to be tailored starting from your setting. Nurses are a linchpin of different healthcare providers, and for this reason could be very strategic in implementing school-based educational curriculum to enhance the daily toothbrushing as a part of the activity of the educators. And thank you. With these few messages, I finished my intervention about the role of school nurses in education related to toothbrushing. Thank you.
Rosario, thank you very much. I think we're beginning to get a picture of this integrated approach, including teachers, including other pupils, including dental students. And I think the school nurses play a very, very important part. And it's maybe something that needs to be helped and shaped, how that can be a synergy in achieving better oral health and, in fact, better health generally for our school children. We've got some Q&As, and this is open to all the speakers. I'm looking at some of the questions people have posed. We've had one from the Middle East, which is about resistance. Did any of the speakers find resistance from school authorities or from parents about introducing toothbrushing in schools?
Yes, we found that I was looking at the questions there. We don't really get resistance from parents. You know, they're quite happy with it. You occasionally get resistance from a head teacher though, because they might not see it as a traditional education, you know, sort of activity. But not, that's the only thing that happens sometimes to us.
Okay, thank you. Sonia, did you find resistance in Brazil?
Yeah, we have resistance from the teachers because they think they receive very low salary, and to put this all one more thing for her, it's too much. And we have to adapt ourselves to their daily activities, not to disturb the class. So that's important that we stay the whole day and not disturb the activities they have to engage them in our problem. And one other thing I would like to say that on the 7th grade, they study science, and this study there is on the books oral health. So that's a way that we can also try to decrease this resistance, but it's not easy.
Okay, thank you. Anyone?
Raman?
Sorry, Jaime.
Well, in our experience, the resistance was from the authorities saying that the teachers wouldn't comply, but we were very surprised that it was the other way around. Many teachers said, you know, this is something that was missing. And so it was more from the head of the teachers. But once it permeated down, and again, as I told you at the beginning, the smaller the children, the teachers were more, they embraced the program easier. You know, with the older kids, it was more a problem of control of discipline, because at the beginning it became like you know, it looked disorganized. But once they get into this daily thing of repetition, then in the schools, we haven't had that problem so far.
Okay. And Mahesh, in India, I was very impressed with the fact that we're teaching brushing as a routine behavior, and these midday meals seemed like a very good hook to put this into. So can you just share with us a little bit about the midday meal scenario that happens in schools in India, and how toothbrushing could be slotted in there?
Yes. You know, midday meal, it is mandatory that the meal is cooked. You know, it is all support is provided by the state governments, and the meal is cooked very hygienically in the school, and it is served you know, to the school children. And most of the school children don't carry the tiffin; they don't carry the lunch to the school. And also, you know, it is not just meal, but I think it's planned in such a way so that entire nutrition is taken care of. But I would like to share with you that there have been instances in India that you know, sometimes some of these activities which involves some intervention on children have been registered by the parents, where they say that and you know, because of that, mostly whenever there is some intervention, immunization or any such intervention is required, then usually the teacher would ask the child you know, to bring a kind of a consent, you know, or the consent is sought from the parents, because sometimes, you know, they say that it was done without my consent. So, you know, because we have all kinds of you know, all kinds of people in the society, especially with the more liberated thoughts now, there have been instances. It's a very good question that we not think it is implied consent, the very fact that they have sent the children to the school. that we can ask them to do some of these, even though very, very useful activities, but I think somewhere the consent is taken from the parents. Yes.
Good, thank you very much. We have a question, Rosario, for you about how do you think that school nurses and the dental community could work closer together?
Great question. The best way to work together, in my opinion, is to find a way to have common and shared places where perform activities. For example, I think that the scientific society of the dental community and the nurses could be very helpful to help to integrate multi-professional perspectives in one plan to action. So in my opinion, it's basically a cultural barrier sometimes to find the energy to work together to face with the same problem. And I think that scientific society, professional associations, and also the demands from our stakeholders are often common. So considering that the demands are common, of course, we have to find a systemic modus operandi to work together, to work closely together, because sometimes the problem is related that working together is something of extra routine, extraordinary. So we have to find a way, find programs, find strategies where working together is just a routine, is just a common practice. Because when we put together different professionalities, different perspectives, we contribute a lot in create the ecosystem that is needed to promote health. So this is this is what, in my opinion, is very important to incentivize collaboration among professionals.
Good. Yeah, so thank you very much. I agree with that. Our time is coming close to an end, and I'm going to give each one of our 5 speakers just an opportunity to underline one of the key things they think is important as we consider toothbrushing and other oral health programs in school. So Alex, if we start with you.
Hi. Well, we were thinking about improvements to the programme in future. One thing we're worried about is if they brush the teeth in the morning, you get children that come to school in the afternoon. So we should keep an eye on that. And we're going to lower the age of the toothbrushing down to 2 years old, hopefully, and also expand the toothbrushing into what's currently the school holidays. So there will be nursery school education during what is now a holiday.
Good, thank you very much. Mahesh?
Indian, geographic and population is quite similar to Mexico. And I think, we should integrate toothbrushing, mandatory toothbrushing in, with our midday meal scheme and hand hygiene, midday meal scheme followed by toothbrushing. I think if, this is something which is a need of the hour, and if this is something like this can be done through legislation or by some means, I think this will be a great way forward.
Good, thank you. Jaime.
Thank you, Herman. Well, I think that there were 2 key issues here. One was make them feel that toothbrushing had always had to be in school. It was not a new thing. It was, in some instances, a budget thing, because soap and paper to wash your hands and water is normally in school. and the toothbrush and the toothpaste has to be added. And in underserved populations, they don't have the money to get it. So we made them feel that it was it had always had to be in there, and we were correcting the story. And number two, I think that programs that don't have a lot of dental influence is the future, because dentists are given the role of restoring or keeping the health of the patients, and they normally don't have the time for education and education in prevention. And not in many countries there are hygienists or dental nurses. So I think the teachers, when they understand, they're going to be a very, very important stakeholder for the future of good oral health in the world.
Thank you. Rosario, is there some final comments you would like to make?
Yeah, I think that we have very clear in mind that schools are places where we have to, are the places where health promotion should start. So giving this in mind, when we have in mind, or we have the willing to go ahead with programs related to oral health, toothbrushing, etc., we have to very clearly consider that that we have to intercept together healthcare providers and educators and managers the demand of health from our stakeholders and move with common and shared programs. When we start a program, we have to move together. And this is what I experienced when we succeed in some programs. When we start together, because the barriers is at the beginning often of the resistance in some programs are at the beginning of the experiences. But when it become a routine, I have experienced that everything moves to succeed. This was I want to share with you as a follow.
Yeah, thank you so much. Sonia.
I think we all agree that school-based toothbrush is something very useful and good for health, and the habit from the young age will develop adults with health habits. But I think as it was also said, it's necessary to motivate, not only to inform. And I think when we motivate, it's important to let it clear that toothbrushing, it's not only for caries, but it's for health in general. So when you can join this with other programs, we get more success and more acceptance, I think. And that's still, it's very important. And we also need to look for, at least in Brazil, for private partnership in order to increase this program.
Good, thank you very much. If we have the next slide, the take-home messages. I want to thank all the speakers. I think it's been very good. It's been very diverse backgrounds. I think one of the things we want to get over, and I think we've learned today, is there is a global oral health crisis in children, and we can't neglect that. And it's not the responsibility of just the dental community. It's not the responsibility of one individual or groups of individuals. It is everyone's responsibility. And we have to, and what Scotland have shown us is the improvements we can see in a school-based toothbrushing program with a fluoridated toothpaste. The difficulty is that so often that is placed in the health budget or an external budget. And what India has shown us is that it's a part of daily routines. You have your midday meals, that's provided by the educational system. You wash your hands beforehand and you brush your teeth as well. That should be part of an integrated approach to providing good care. But also we've learned that from Rosario, the importance of including the school nurses who have a role to play within schools and integrating their work and their messages to improve oral health. And they should be part of the team, as should the teachers who introduced brushing into the curriculum. No child knows how to brush their teeth. It's not an intrinsic behavior. They have to be taught to brush their teeth. And of course, parents undertake that role, but it has to be reinforced and supplemented at a school-based level within the curriculum and within everyday habits. So these are the take-home messages for me, that school-based education has so often been parallel and undertaken by parachuting dental teams into schools, when actually the best way is to integrate it all within integrated structure with school nurses, teachers, parents, and also within the daily life of a school. I want to thank everyone again for this interesting webinar. There's a lot of activities that are happening around the world, and I think the key message is integration. We know the importance of integrating oral health and general health to improve healthcare. And now I think we have reinforced and underlined the importance of integration with regard to school-based education, particularly toothbrushing. Next slide, please. So I want to thank everyone. I want to thank our sponsors, the University of Geneva, the Global Child Dental Fund, and Colgate-Palmolive. I want to thank all the people from around the world that are listening to this. And of course, as I said initially, this YouTube would be placed on, this video would be placed on YouTube and other social media platforms, and it will be freely available. And I want to thank all the speakers for participating and allowing their slides and materials to be freely available. Next slide. Our third webinar this year will be the importance of integrating general and oral health, and I ask you to register for that. That will take place November the 15th at 12:30 to 2:30 Central European Time. So with that, I'd like to again thank everyone, and I draw this webinar to a close. Thank you.